Hello, good morning, everyone. Assalamu alaikum. So as Mr. Ahmad mentioned that, dental is one of the hot topic always. And since dental coders, they are aware now, there are a lot of changes going on from last few months in dental. So just that was the purpose of this meeting. So to update you and about denials. And I'm also adding like some previous slides for the new coders so they can learn about dental coding. And also, since as Mr. Ahmad Sheikh said, dental now almost in all facilities they have a dental center, dental clinic in their facility. So all the coder should know about the updates and about dental coding. Okay, so in these slides I will just talk about some terminologies, also some like guidelines, dental guidelines, denials. Okay, for dental charting, all this. So we'll discuss today about all this thing. Okay, so first welcome all to Abu Dhabi local chapter. Okay, so our main topic is dental coding updates, as I mentioned, there are a lot of updates from last few months, especially from the payer side. So all the coders and all the providers should know those updates. Okay, and then we will discuss about the denials also. So today, our content of today's meeting, what we will be discussing will be about the dental claims. Okay, about we will talk about some like mainly used anatomy and terminologies. Okay, then the hard guidelines and claims protocol, then the procedure codes, because this is the Abu Dhabi local chapter, so I'll be only discussing about the UCLS codes, because for Dubai they have the American dental coding, so that will be different for the Dubai chapter. I will be discussing that, but this one is for Abu Dhabi, so I'll be touching only the USCLS codes. Okay, then abbreviation, diagnostic coding, okay, coverage and prior authorizations, and dental denials, and some dental updates. Okay, so dentistry is defined as evaluation, diagnosis, prevention, and treatment. So if you see the medical coding, you have there the E&M code and procedural coding. But dental, we are not using the CPT codes in dental coding. We have, as I mentioned, we are using here in Al Ain Abu Dhabi, we are using the UCLS codes. That is from the Canadian coding. Okay, but in Dubai they are using the American coding. But the ICD-10 codes is same. Okay, whatever you learn in the when you're doing the CPC course, you have the like same book using ICD-10 for diagnostic coding. But for procedure, we are using the USCLS codes. Okay, Canadian coding. So the branch of dentistry, like mostly here we are using like orthodontic. Most of the facility you're familiar with the orthodontics. Okay, prosthodontic, pediatric dentistry. Okay, then the preventive dentistry, endodontic, periodontic, oral maxillofacial, oral pathology, then medicine, then forensic and community dentistry. So elements for dental claims, what you need to have in your dental claim when you are submitting the claim. So you need to have the diagnostic code, okay, then the procedure code, tooth numbers. Okay, so tooth number can be like before some clinics they were using FDI coding or Palmer, but now universal tooth numbering is everyone is using. And then some of the procedure code, you need to get the prior authorization, and that detail should be submitted for the claim submission. Okay, so as here in Al Ain Abu Dhabi, we are following our DUH education rules. Okay, so what we are here is the again the USCLS codes and the universal tooth numbering. Okay, so the claim methodology. So dental is coming under the outpatient. Okay, and the diagnostic dental treatment, preventive, restorative, protein periodontitis, periodontics, prosthodontics, orthodontics, and cosmetics dentistry, as I mentioned in the previous slide. And then for the inpatient or for the daycare, we have the codes for per diem. Okay, about dental anesthesia, because some of the patients, like for dentistry, not all the patients they need the anesthesia, for the normal restoration, scaling, polishing, these things. But sometimes, if the patient is uncooperative or in a daycare or this one, you need to have the anesthesia. Okay, especially some for the special care need patients. Okay, and especially for the pediatric patients, they are uncooperative, so they need to have the sedation to do the dental treatment. Okay, so type of sedation, we have the general anesthesia, which they give, especially when they are doing the daycare or for the any trauma cases. So they have to give the general anesthesia. Then deep sedation with IV, mild or moderate sedation, and nitrous oxide they are giving in the clinics, especially, again for the pediatric patient when they are uncooperative. So they need to give the nitrous oxide. So most of I think you are familiar with the last one because this is giving in the dental clinics itself. So these are the codes using for the anesthesia. But since these codes are bundled with the procedure code, so we cannot claim for these codes. For the IPO for the daycare, we are using CPT codes. So as I mentioned, in the dental clinic, we cannot use this code. But since when the patient is in the IP or in the hospital setup, then you can use these CPT codes 0170 and 90. Okay, so dental anatomy and anatomy and the terminology. So whenever you talk about dental coding, for the coders, it is very important to know the dental terminology and anatomy, because once you will be familiar with the anatomy and the terminology, then only you can assign the appropriate code. Okay, so you have to know, for example, this if you see this picture and the tooth structure, if you see this one, this is the enamel, dentine, and pulp. So since dental coders, they are aware that for even diagnostic coding, even the procedure, especially for diagnostic coding, you have different code for if patient have caries into enamel, you have different diagnostic code, and then if you have into dentine, different, and in pulp, they different code. So that's why you need to know the terminology. Okay, sometimes some doctors they in their documentation they are putting only patient have dental caries. So in such case, you need to query physician to write the depth and the surface of caries, so you can assign the correct code. Okay, so you have to know the anatomy, tooth numbering. Okay, and even if you see the for primary teeth and for the adult teeth, they are different tooth numbering. Okay, so all these things you have to know. Okay, and sometimes you have to know like for about X-rays also, when because mostly doctors they are posting the X-rays on the in their notes, so you have to know about this terminology also. Okay, so since you're familiar that we have like primary dentition and the permanent dentition. Okay, so if we talk about the primary dentition, again we have different tooth numbering. Okay, those are like alphabetical. Okay, so when doctor is working on doing any treatment on the primary teeth, make sure that doctor is documenting correct tooth numbering. Okay, so sometimes so it's happening, when there's new coder or even new doctor, they are not familiar that like which tooth number they have to add. So you need to query physician. Sometimes the patient is having the multiple mixed dentition. Okay, so after like age of 12 or 15, you will have patient will have different tooth numbering like mixed dentition. Okay, so in such case, you need to be very careful. Maybe doctor, for example, doctor have removed tooth number A. Okay, so now patient is having already the permanent tooth there, and maybe he's doing, for example, the RCT treatment on the permanent teeth. So by mistake, maybe he put tooth number A again. So you will get denial for that because tooth number A was already removed, and now doctor is working on the permanent teeth. So as a coder, you need to query the physician if you have any doubt about tooth numbering. So permanent dentition is like numerical, okay, and as like we're using the universal tooth numbering, okay. So again, as I mentioned, when the patient is in the mixed dentition age, you need to query physician that it is correct tooth number documented or not. Okay, so set of codes using in Abu Dhabi is ICD-10 2018. Then we have the UCLS 2011 version and tooth number universal. Okay, coming to procedural coding. Okay, dental codes, same like for the CPT code we have set of codes, right? In the dental also we have from 1000. If you see this one category of services, okay, we have the 5-digit codes. Okay, all are numerical. Okay, so starting from 1000 to 9,000. Okay, then 10,000 to okay, then 10,000 to 19,000 for prevention. 20 to 29,000 aspiration, 30 to 39,000 is endodontic, 40 to 49 is periodontic, 50 to 59 is prosthodontic removable, then 60 to 69 is prosthodontic fixed, 70 to 79 is for oral and maxillofacial surgery, then 80 to 89,000 is orthodontic. Then the last one is 90 to 99,000 is like other services. Okay, so if you read in the our like USLS book, you have different codes there. Okay, some codes are like laboratory services are extra. Okay, then some they have the time-based code. Okay, so you'll find these terms in that in your book. Okay, so this one L is the laboratory procedure extra. Okay, so if it's time-based code, like all coders are familiar with this one, second time-based code. We have, for example, scaling, polishing, microabrasion, these things. Those are time-based code. So always first unit is 15 minutes. Okay, make sure that your doctor is documenting the correct timing. Okay, since I mentioned that we are using universal tooth numbering. So if you see this one for the permanent teeth, we have from 1 to 32. Okay, and for the primary teeth, we have from A to T. Okay, so sometime you have also the supernumerary tooth that I will share with the other slide. So about tooth numbering, why you have to know tooth numbering? Because for the many procedure for example restoration, we have different procedure code for the posterior, different for the like bicuspids, and different for anterior. So again, as a coder, you have to know that which tooth number is in which area and what code we have to assign. Okay, and for example, we have, for example, extraction codes also like per quadrant. Okay, so if it is the same quadrant, two tooth are removed. So you have to know tooth number. For example, one tooth is removed for tooth number 7 and 8. So for simple extraction, as you know that if it is same quadrant, we have to assign 71101 and 71109 if same quadrant. Okay, so that's why it is very important for coders to know the tooth numbers and in which quadrant that tooth number is located. Then for the primary teeth, okay, so if you see this one from A to T, so you have to know. And again, like some extraction codes, for example, surgical extractions, we cannot bill for the primary teeth most of the cases. Okay, so make sure that you are familiar with the tooth numbering also. So if you see this chart, before like some clinics they were using the Palmer and some they were using FDI. Even now some clinics they are using the FDI, but once you submit the claim automatically from the payer side it will convert to the universal. Okay, so see this one, if you see this one universal. Okay, from 1 to 32 is universal. So if you see this one, the FDI, this was per quadrant. For example, this one first quadrant, first tooth number. So first quadrant, second tooth number. So before many clinics were using the FTA, but now most of clinics are using the universal. But still some clinics they use the FTA tooth numbering, which is when you're putting this one. So if you have like such software which will convert automatically FDI to universal, so that is much better. Because if by mistake you will submit this tooth number, you will the payer side they will know that this is the universal. So you might get rejection for that. Okay, so make sure that you are using the correct tooth number. That is universal tooth numbering. Okay, so this is the most important part about dental documentation. So whenever doctor is adding documentation, you need to make sure that doctor is adding all these elements in that documentation. So first thing, the chief complaint. Okay, so chief complaint is also sometimes affecting the diagnostic code as well as the procedure. Okay, so for example, patient is coming for checkup. Okay, checkup and first visit and patient want checkup only. So doctor, for example, he will put that patient is for screening or for checkup. So this chief complaint itself will change the diagnostic code. Okay, since you know that we have like Z series code. like encounter for dental screening and cleaning. So chief complaint itself will change the diagnostic code. So make sure that your doctor is always writing the chief complaint according to that encounter. And for example, patient is coming with for example, severe bleeding, or he's coming with the severe pain. So you know that this will also affect the procedure code also. For example, we have the emergency dental examination code. Okay, so if chief complaint is patient has severe dental pain, so this will be going directly to that emergency dental examination. Then we have history of present illness. So in this part, doctor will be writing in more detail, like for example, now patient came for checkup and he has any history. Maybe he has any trauma, or he has pain from same like medical like coding documentation. He will write the history, how this, for example, patient came with a trauma. So doctor has to write here that how this trauma happened and what kind of injury happened. Okay, he has broken teeth or he has like mobile teeth. So he need to write in this area in documentation. Then if he has any past or a medical history, so in this part he will write all the details. Then any family or social history, maybe sometimes patient is, maybe he's like athletic or this one, so doctor need to write here. So the most important part is this one: dental charting, intraoral examination, extraoral examination, and hard and soft tissue examination. So this is the most important part where doctor will write all his findings. Okay, so as I mentioned in the previous slide, for example, patient have caries. So in this area, doctor will write exactly which tooth number has caries, what is the depth of caries, and what is the surface of caries. For example, patient have caries on tooth number 2, okay, and it is reaching to the pulp. Doctor need to write very clearly that patient has caries on such and such teeth and into pulp, for example, and then plus he need to write the surface name also. It is from the occlusal surface, from the mesial, distal. So everything he has to mention. For example, doctor will be doing the 3 surface restoration. Okay, and here in the intraoral examination he write only 2. Okay, so that will conflict. So you need to query the physician to add the correct surface name and the numbers in the intraoral examination and in the progress note. Then we have the radiograph findings. Okay, so since you know that for dental we have the different kind of radiographs, and there are some updates also that we'll be discussing on the other slides. Okay, so radiographs, whenever doctor is taking, even it is billable or no, still doctor need to write the purpose of taking the radiograph plus the findings. Sometimes there will be no findings. For example, patient has pain in the posterior teeth, so doctor need to have the white teeth, for example. Okay, and when he take the X-ray, there is no, everything is fine. Okay, still doctor need to document that radiograph was taken because patient has pain in tooth number 30 or 31, for example, but there is no caries, everything is like normal. Okay, so still he need to document that radiograph was taken for this purpose, and there are no abnormal findings. Then we have the narrative diagnosis. So narrative diagnosis are like justifying your diagnostic code. Okay, so it is narration. Okay, so for example, patient have, for example, the abscess. Okay, abscess. So the code, for example, you are using is a periapical abscess with sinus. But here he can just write itself in the intraoral examination, he will write an infection, and here he will write more detailed diagnosis. Okay, so which should justify that diagnostic code. So then again, important part is the procedure note with detailed. Okay, detailed mean, for example, doctor has done the scaling and polishing, so he can only write scaling and polishing done. Okay, so since I mentioned in the previous slide that the scaling and polishing is time-based code, so first thing he will write that what time he start the scaling and what time he has completed the scaling. Okay, then he need to write what kind of instrument he has used. Okay, it is not like a normal scale, like scaler, or like ultrasonic scaler. Okay, and he will write detailed note. Okay, he has used ultrasonic scaler and effusion was removed, bleeding was controlled. So all this detail he need to write. Okay, same for the procedure for example, restoration. So he need to write that what kind of filling was done. It was composite filling, it was GI filling, or whatever. So, and which tooth number, surface of the restored tooth. So all these details he need to write in the procedure note. And tooth number, of course, it need to be documented accurately. Whatever you have bill, so you need to write same tooth number in the notes. Then we have the follow up in the patient education in the treatment planning for the next visits. Okay, dental charting and dental abbreviations. So since like when doctor is doing the screening, especially for the first visit, he will take he will use the dental charts. Okay, so that chart again need to be like color coded. Some software they have this one, the color coding tool in their software. So for example, patient have a caries, they will highlight with a red. For restoration, they will put a blue. Like this one, you need to have this one, and like you need to keep this charting in your software, in your documentation. Especially when you are billing for the full mouth examination, then you must have the dental charting in your notes. Okay, then the abbreviation we're using. Okay, so for example, if you see this one for the arch, upper arch we are using UA, lower arch LA, and for the quadrants, upper left quadrant, upper right. So this abbreviation you can also use in your doctors can use in their documentation. Okay, so if doctor has mentioned prophylaxis done, it means caring and polishing done. If he has mentioned that OHI given, so it means oral hygiene instructions are given. So same for all this. If you see this one, the infiltration, then the nerve block. Okay, so these all terms you need to know. So this is an example of dental charting. So if you see this one, some like EMR system, they are having this kind of charting. Okay, so if they put a cross, it means the missing teeth. Okay, if they have, for example, this one, they have a post and core. So this is a very good example. If you see, it's very clearly mentioned that this is class 1 caries, this is golden crown, this is abscess, okay, fracture. So this is actually more clear. If doctor is only putting the color, that it will make some confusion. So better if he will write like this, he will just mark and then he will write that this tooth have, for example, for extraction, and this, for example, for bridge. So this is very, very good example for the dental charting. And if you see the right side, this is the color coding. This is what I mentioned. Some clinics they have this EMR. So if they put cross, it means this is missing teeth. Okay. So if this one, this means this has like implant. Okay. So they're like every EMR have different kind of charting, but make sure that doctor is documenting clearly in the documentation, and then marking the correct number in the charting. So again, there are more abbreviations. So these are especially for when patient have the caries and doctor is doing the restoration. So mostly you will find these, for example, for the facial incisal, then mesial, lingual. So instead of writing full term, doctor can just simply, for example, patient have caries in the mesial occlusal buccal. So he can put only MOB, okay, in his note and plus tooth number. So all these like auditors or whoever or doctors, they will know that what is exactly done on which surface. So if you see this other example, we have like see. So this is the surface of the tooth. Okay, this is the occlusal, facial, lingual, distal. So again, as a coder, you have to be familiar with the tooth surfaces also. Okay, because sometimes doctor will just write, maybe he will just only highlight this one and you have to know. Okay, now coming to the dental ICD-10 codes. Okay, so because our mouth is in our digestive system, so most of codes you will find under the ICD-10 book digestive system, K series. Okay, so if you see the caries code is K series. Okay, so most of codes you will find in the K series, but like we have other codes also, Z series and M series. Okay, so if you see for the orthodontic, we have M series. Okay, so most of the orthodontic codes you will find under the M series codes. Okay, for example, we have malocclusions, okay, crowding, spacing. So all these lies under the M series. Then we have the S series also. Sometimes we are having the like fracture or trauma cases. Those lies under the S series or the dislocation of the tooth. So what is important here when you are assigning the fracture tooth code, you need to have the external cause, because external cause will be there will be different code. For example, patient fall, so that will be under like W series. So like external cause always, if doctor did not mention, so you need to query the physician that like what kind of injury was done and how it happened. It was trauma, it was fall, it was hit, because according to that you can assign the external cause. Okay, this slide especially why I clearly mentioned, because some coders they're confused with the fracture tooth or for the broken tooth, cracked tooth, or fracture restoration, unsatisfactory, because we have many codes lying under this, the second one. Okay, so fracture tooth is clearly, when the natural teeth is fractured. Okay, so now the question is here now the fracture and the cracked tooth. Okay, so fracture mean, if the like a part of the teeth is like fractured, or it is broken down or fell down. Okay, so we can assign this code with external code. But crack, if you see this picture on the right side. Okay, so crack, if we are talking about it like in the general, we are talk about for example crack mirror, for example. So crack means there is crack line on the teeth. Okay, like this one. Okay, see this one, crack tooth, this one non-treatable, split tooth. Okay, so these are coming under crack. But if it is broken, mean this one. But this one doctor have to, because we are not every time seeing the X-ray. We don't see that tooth, right? So it is doctor who is treating the patient, and he is familiar that what kind of like case he is seeing. So you need to query physician again to confirm that it was crack or fracture. So and either way, whatever he has documented, you need to assign the coding according to that. If doctor has documented fracture tooth, you need to assign this one. You cannot assign the crack. Okay. If he has documented crack, you cannot assign the broken. Now coming to this code case series for the fracture restoration or open margin or unsatisfactory. So they are like different. So now again, some doctor they are documenting open margin, but the coder is assigning this code. That is also wrong. So open margin is K08.51. Actually, I forgot to write here. So it is 51. And then fracture restoration, again, we have, if you see, there are three codes: with loss, without loss. Okay. And this is also like you don't know how it is that code. Okay. So you have to doctor into document according to that you need to sign the code according to the documentation. Okay. If it's with loss, so with loss is if the part of that restoration is gone. Okay. Without loss means it is only fracture restoration. Okay. So you need to query the physician if you have any doubt about this one. So this is one of the like examples for the crack and the fracture tooth. Okay, so if you see this, for example, this is clearly like broken tooth. Okay, we cannot like say this is the crack tooth. Okay, so crack are these like this. If this line, this is example here. See this one. This is crack tooth. Okay, and this diagram is for the fracture restoration. Clearly, we can see here this is restoration, and this is broken restoration with loss. Even we can say. Okay. Okay, so as I mentioned, that we have the categories of codes. Okay, starting from 1,000 to 99,000. Okay, so this already I mentioned in the previous slide that we have for different service we have different category of codes, diagnostic, and then all these services. Okay, so will we go one by one for the each this one? Okay, starting from evaluation. Okay, we have the dental examination codes that lies under the 01000 category. Okay, so most of the examination codes you will find in this, okay, this 01000 category. Okay, so dental examination codes. So since you know that now there's a few updates about dental examination, when to bill, so that I'll be discussing in the next slide. Okay, so make sure that even it is bill payer is paying or not, still you have to document, this examination, and you have to bill this one even with the zero like billable amount. Okay, so for GP we have different like procedure codes. For the ortho we have different. Okay, for prosto, if you see on the left side, okay, we have like multiple codes for the dental examination. Okay, we have full mouth examination, we have like limited examination, then we have the specific emergency examination. Okay, so if you see this, all this we have all specialty. Okay, surgical, prosthodontic, endo, ortho, so all this one. So all are familiar that like for the ortho we need approval, right? And this is for the second opinion. So all this procedure code for examination, you have to know when to bill it. Okay. So again, I will be discussing in the other slides for this detail. Okay, so if you this one 01201, this is for the new patient limited. Okay, so this code we are billing for the limited exam. Okay, and if you see description of this code, this is for the new patient and limited. Okay, new patient limited. So if the patient is coming first time, just for the only for the limited exam, you can bill this one. But if it is in case he need full mouth examination, then it will be 0101 or 02 or 03. Then we have 01202. Okay, so this is for the recall. Okay, so this is like if patient is having the same tooth number or same diagnosis, then you can bill 01202. Okay, but again there is update, so keep in mind that update that we can bill only now examination after 6 months. Okay, so make sure that you are following that guideline. Then we have specific examination. Okay, so for example, if previous was done on the tooth number 3 and this time in other teeth, then we can bill for the specific exam. So this one is emergency. Okay, whenever patient is coming for any emergency case for with abscess or with severe pain or with a bleeding, fracture tooth, okay, any trauma, okay, so you can always bill this one. Again, again I'm repeating that. For example, patient came like only last month for the examination, and now he's coming for the emergency. You cannot bill. You can bill this one with zero amount. Okay, don't if you bill, you'll get denial. You cannot claim this one. Okay, we have the examination. When a patient is coming for any checkup, if patient has pain, first thing what doctor will do, he will do the visual examination, right? He will see if there is anything he can see. He will open the patient mouth and he will see if patient has any broken tooth, he has any caries. But sometimes doctor, if patient has, for example, any pain in the posterior teeth and doctor cannot see anything visually, is not, for example, caries he has in between two teeth, so he will request the X-rays. Okay, so like he need to inspect more detail, like with the X-rays or with the OPG. So he will request for X-rays. So we have like different two methods. One is visual, one is the radiographic method. So in the radiograph dental, we have the bite wings, we have the IOPAs, we have the OPGs. Okay, then the tomographies. So according to the specialty or according to the that case to case, doctor will request for the X-ray. So as I mentioned, in dental we have different kind of X-rays. We have bite wings. Okay, we have the P X-rays. Okay, and we have the tomography. Okay, then we have the spirometric. So these are like example of the X-rays. If you see this bite wing, P X-ray, okay, tomography, okay, OPG, and like closal intraoral examination, the radiographs. So this is the update. Recently, I think all of the coders are familiar that P X-rays and being no more billable under the Manortika. OPG once per year. So whenever you are billing for talking about the X-rays, just you need to know that what is the update from the payer side. Okay, even the Manthika or whatever whatever insurance you have, make sure that when what is their update, they will pay you or like 6 months or 1 year. Okay, so you have to know the update from them. OPG once per year. Before it was 6 months, and cephalometric also once per year. Okay, then talking about the preventive services, from 10,000 to 19,000. So these lies under the like mostly you will find the scaling, polishing, okay, all this under the prevention services. Okay, so diagnostic code mostly you're using is accretion and gingivitis, according to the doctor's documentation. Okay, so make sure that again these like most of the codes under this one you will find the time-based codes. So make sure you like doctor is documenting the start and end time, and you are coding out according to that. So these are the code for scaling, polishing. Okay, again, these are time-based code. Plus, you have to know that like within 6 months, you cannot bill this one. Okay, so and for the like some payers, when you have audits, so make sure that for the cash patient, you are assigning the correct additional code. Okay, if it is the like multiple units, so you have to be familiar that which code to add when you're billing for the cash, because like some payers they have only two codes. Okay, for example 1101 and 1109. Okay, but if we talk about the cash patient, you can assign according to in the whatever is in the book. Okay, then 20,000 to 29,000, these are the mostly used codes in the procedure for dental procedures, restoration codes. Okay, so 20 to 29,000 are all about the restoration. Okay, so again, as I mentioned that as a coder, you have to know that decay is into dentine or into enamel or into pulp. Okay, so because doctor is the one who is treating the patient, but if doctor will document only patient have caries on tooth number ABC. Okay, so you need to query the physician that doctor need to document the surface and depth of caries. Okay, so these are the diagnostic code. As I mentioned, the terminology you have to know. If patient has the caries into enamel, so this is the code 6 in the 261. Okay, if it is into dentine, then into pulp. So again, we have caries into enamel, into dentine, into pulp, right? So doctor need to document plus the surface name also he need to document. The procedure codes for restoration also lies under the like 21,000 series. Okay, this one. So if you see there are a lot of codes for restoration. Again, as I mentioned before, like doctor need to clearly write what kind of material he has used to restore the teeth. Okay, and how many surfaces he has did the restoration. Okay, and all this detail he need to document, and again you need to assign the code according to that. Okay, if you see this one, we have different materials used here: composite filling, glass ionomer, silver amalgam. Even some patients they are doing the gold filling also. Okay, so according to that you need to give the procedure code. There are some notes here. If doctor is doing multiple restoration on one teeth, some coders they are assigning like multiple times the same code. For example, doctor has done the like three surface. For example, he has done the occlusal, then distal, mesial. So we cannot bill one code 3 times. Okay, so this is very important for the coder to know that we cannot bill restoration code multiple times. Okay, it should be one time. So for example, he has occlusal distal. So instead of billing 3 times, you will take this code, 3 surface code. Okay. So this is example only. Okay. So like same for the composite filling, same for amalgam. So how many surfaces he has filled, you need to assign one code. You cannot fill multiple times one code. Okay. You will get denial for that. Okay. So make sure that you are familiar with this. Coming to the endodontic codes, RCTs, pulpectomies. Okay. So 30,000 to 39,000 are all about the endodontics. Okay. For example, you have pulpectomy, pulpotomy, okay, root canal, retreatments, okay. So it will lie under the this one, 30 to 39,000. So again, there is update, like before GP can do the re-RCT. Now only if they have such case for retreatment, they need to refer to the endodontic. Okay. So mostly used code for diagnostic code for endodontics are these one. Irreversible piters, reversible piters, and the necrosis, case into pulp, abscess. Okay. So again, according to the documentation, you need to assign the diagnostic code. And if you see the procedure codes, those are per canal. So again, the working length and the name of canal, doctor need to document. In case these things are missing, like doctor forget to write the number of canals or name of canals and the working length, you need to always query physician to write and complete the documentation. Okay, so if you see this one, these are all our codes for the endodontics, for the RCTs. Okay, coming to the periodontic. So if you see the diagnostic code again, same what we use for the scaling, pausing, or the accretion, same K05 series mostly you will find for the periodontics. In the procedure code 40 to 49,000. Okay. So again, there's update that again before gingivectomies, okay, and frenectomy or gingivectomy, especially before GP dentist can do. But now again, if you have any case in any GP dentist have any case for the gingivectomy, you simply need to just refer it to periodontist. Okay. So mostly like periodontists are doing the frenectomies, okay, gingivectomies, okay, and these codes are per sextant, okay. So again, and make sure that if doctor is doing the multiple tooth gingivectomy on the same sextant, you cannot bill multiple times. So per sextant mean, okay, so there is sextant like 3 sextant in each quadrant, okay. So you have to be familiar with the sextant codes, okay, or per sides codes, okay. Then we have the diagnostic code. We have the periodontitis. Okay. So again, you have multiple codes of periodontitis. So you have to know that the severity of this one, and then you need to know that it is aggressive, it is chronic, or it is only acute. Okay. So according to that, again, you can assign. If you see this left side, there are multiple codes. Okay. So if doctor just simply write patient have periodontitis, again, you need to query the physician that he need to write the severity, it is light, moderate, or severe. Another thing he need to write it is like chronic, acute. Okay. So all these detail need to be documented. Okay. And in the progress note, he need to write that, okay, he had done the, for example, the gingivectomy on which side. And coming to the frenectomy code, if you see this, we have two kind of frenectomies. Okay, one is for the lingual and the labial. Okay, so lingual is when there is tongue tie. Okay, so again, doctor sometimes they are just putting in the progress note that he has done a frenectomy, and they forget to write the like where exactly it is done. It is on the labial or it is on the lingual. Okay, because according to that you can only code is same procedure code, but documentation should be very clear that on which side he has done the incision. Okay, so if you see for the lip, there is this he need to write that it is done on the lip side. If it is tongue tie, he need to write like clearly it is on the tongue. Okay, so this I mentioned that you need to write the site. So these are the codes, okay, mostly used for the periodontitis, periodontist, okay, these codes. So now coming to the prosthodontic codes. So this again, most of coders are familiar with this code when you're sending the approvals, okay, because most of these codes, like even for the different provider have different categories of code when to send approval. But if you're talking about, for example, Thika or the MAN, Thika especially, so these are the high value codes for the prosthodontic. So you need to know that there is one list. I'm sure that all the coders they are familiar. There is one list of codes where which code need approval and which doesn't require. Okay, so always when you have such cases, always make sure to have that list. Okay, so if any because if you bill any code without approval, you will get denial, right? So make sure that you are familiar with that list, that which code need approval and which doesn't require. Okay, so I think let me show you that list. That will help you actually. So see this list, I think all of you have. This is for like one of the pairs. So if you have this list, if you see on the right side, you can see my screen. Yeah, you see this one, this Excel. I'm sure all of the coders you have this list. This is for actually from the one of the pair from the month. So if you see this, no, this means this code doesn't require any approval. Okay. So if you click here and if you press yes, so this means these all code need approvals. Okay, so all the coders, so this especially for the dental new coders, they're not familiar with this thing. So every time they get denials, okay. So this is one of the reason of auth1 denials, okay. So you need to have this list handy with you in your save in your PC. Okay, so always whenever you have the, especially for the orthodontic, prosthodontic, periodontist, okay, so you need to know that which code need approval. Okay, so simply you can have this one if you put no. Okay, it will show you this code doesn't require any approval. Okay, if you press yes, so all these codes need the approval. Okay, so if you don't have this one, let me know. I will be sharing with you later on. Okay, coming back to the slides. Okay, so now there are like some important points to note when you are coding for the prosthodontics. Okay, let's talk first about the diagnostic code. So again, we have a lot of codes for the missing teeth. If it is like some missing teeth or multiple missing teeth, or you have the complete missing teeth in one arch. Okay, so still some codes they are confused with these codes. Okay, diagnostic codes. Let me go to next slide. So let's talk about this one first. Okay, so if you see the missing teeth codes, we have multiple codes. So always ask your doctor to document very clearly that he like that missing teeth is due to trauma, due to caries. Maybe that tooth was extracted in your facility. So from there you can clearly know that it maybe he extracted due to caries. Okay, so maybe periodontal disease, maybe due to trauma that the patient lost the teeth. Okay, so it is doctor's part to write that document very clearly that missing due to what. And then second thing is the class. Okay, so class 1, class 2. So this is the currently like missing teeth classification. So again, if you are not familiar with that one, always ask doctor to write the class of the missing teeth. Okay, so class and the cause of missing teeth is very important. Okay, so in case doctor just write missing teeth to number this one. So as a coder again, you have to query physician and ask him to write the details of missing teeth, cause and the class of the missing teeth. Some cases you can go in the previous documentation to know, like if you have if you just go to the previous documentation, you will find that that tooth maybe is extracted due to caries. In some cases, doctor they are, for example, they are doing immediate implant, so they just remove the teeth because that was unrestorable, okay, due to caries or due to any periodontal disease, and doctor extract and they just put the implant. So in such case, you will know. But if you just put only missing teeth, then you have always query the physician. Okay, now if you see on the left side, these are partial loss of teeth, and the right side, complete. Again, now some confusion with the coders, what mean complete and what mean partial. Some coder, they are taking, if one tooth is like part is missing, one, like for example, he has chipped teeth. So they they are coding this one, partial loss. Yes, maybe you can, if you see that like coding language, maybe you can take this code. But in the if you are talking about the prosthodontic, okay, this code we're using when patient have in one arch, he has, for example, he has even one teeth remaining, still you will consider that one as partial loss of teeth. If he has he has no teeth at all in one arch, for example, then you can consider that one as complete missing. Why? Because we have the denture codes. See this for example, okay, patient have, for example, these two teeth, okay. Let me make it big. Okay, this is one example. Okay, this is a denture, but I'm just giving example. If it is natural teeth, if patient have these teeth and this is all missing, this is still partial missing teeth. Okay, okay. So this is denture. Okay, I'm talking about natural teeth. Okay, so if patient has complete missing teeth in one arch, okay, so that is called complete missing. So in such case, you will be assigning these codes. Okay. So first thing, as I mentioned, you need to know the missing teeth class in the cause. The second thing is you have to know that it is what is partial and what is complete. Because we have denture procedure codes, denture, complete denture, or partial. So if you have only partial denture, you are sending complete denture diagnostic, again you will be getting rejection for that. Okay, so again you have to be very clear with this one. Okay, coming back to this slide again. Procedure codes are lying under 50 to 59,000. Okay, so if you see the dentures, okay, so this is removable. Okay, so there are two, like fixed and removable. So removable is the about dentures all. Okay, so again for procedure coding, you have to know that patient has like complete denture. Okay, so if you see this code, you have for the upper arch and for the lower arch, maxillary mandibular. Okay, so make sure that you are assigning the lot of code, procedure code for the dentures according to the material, lab made, okay, or you see this one, so a lot of queries, okay, standard, complex. So this only doctor can know that what kind of like material or what kind of denture he's using. So according to that, you need to assign the code. Now coming to the fixed orthodontic, we have, see this one, all you have the like implants or you have the bridges, okay. So again, these are lying under the 60 to 69,000 series. Okay. So again, for bridge, we have a lot of codes. Okay. We have acrylic, we have the porcelain. Okay. So make sure that you are assigning the correct procedure codes. Okay. Also, bridge contains like retainers and pontics. Okay. So make sure that the doctor is documenting correct and you are billing the correct procedure codes for the bridge. Okay. Same for the implants. Okay, implants we have like different kinds of implants. Okay, so you have to be familiar with all these things. So again, these codes, like some of these codes, they need approval. So again, you have to go back to that Excel I was showing you. You have to know that which code need approval. Some of the pontics, for example, they need approval. Some of the pontics, they doesn't require. Even same for the retainers. Okay, so again, make sure that you are familiar with that. Which code need approval and which not. Okay, so simply you can go to that Excel and you can just simply click yes or no, and you will know. Okay. Now coming to some coverages and the coverage and effects. Okay, so orthodontic treatment. So since orthodontic treatment, not all the cases are covered, so it depends on the prior authorization. And of course, the payer side, they will ask you to send them the assessment form, okay, and then the X-rays, plus some payers, they'll send patient for second opinion to make sure that that patient really need the orthodontic or no, okay. Okay, so you have to know that, and so on, okay. Then for the major dental surgeries, okay, so for the trauma cases or any removal of excess, so some we have surgeries, okay. So since like some of the we have GA cases also, okay, trauma cases, so that will be under the major surgeries day case. Then we have the cosmetic treatments are not covered, okay. For example, you have veneers, bleaching, and there are a lot of other like codes under cosmetic which is not covered. Okay, for example, the gum bleaching or like tooth bleaching, these are not covered. So coming back now to the recently updates. Okay, so these are now recent updates from Daman. Okay, so dental X-ray before you can bill, right? For PA X-ray and white wings. But now if you see this one, dental X-ray will no longer be able to by instead be considered an integral component of dental consultation examination. Okay, so it means if doctor is taking the X-ray, okay, you cannot claim it, but still you can bill under the cash, okay, and you need to have the documentation and finding of X-ray. Okay, OPG is now okay. So you can bill this one for the once per year. Okay, CPCT and OPG once per year. So always when doctor is taking the X-ray, make sure that you are saving in your PC for the future audits and for the patient record. Always keep in your system. Okay, dental examination. So dental examination is now you can bill only same like scaling policy. Now you have 6 months. Okay, so as I mentioned in the previous slides that dental examiner we have multiple codes. Okay, so whatever code you are assigning, so after that for the next examination it should be 6 month gap. Okay, make sure that if you are billing within 6 months you will get denial. Okay, so except the orthodontic. Okay, so orthodontic don't count. For example, patient is have done today with the GP, and now he referred to the orthodontic and he bill for orthodontic exam after, for example, 1 month. So it is billable orthodontic. But again, like there is some coders they are confused that like orthodontic can bill orthodontic and plus the other exams. No, it is only about orthodontic exam. The one they're sending in the approval, for example, or for the second opinion 01901 or 01902. Okay, so make sure that when you are billing for dental examination, see the previous exam when it was billed. Okay, and if it is orthodontic exam billed within 6 months, yes, you can bill for other exam. Okay, so you need to make sure this update. Guideline for dental crown indications, and so this is the recently update. Okay, so again, like a lot of questions in our groups and a lot of questions from the coders that when they can bill like primary and when how many crowns GP can bill. So there was scope of service. I think last year all clinics they received that scope of service. So in that one they clearly mentioned that GP can bill 3 crowns per quadrant per arch. Okay, so I'm sure that all of course are familiar with that one. Now new update is that they can bill crown, but this is the update that if the not for the all RCT teeth are not qualified for the dental crown placement. Okay, so they clearly mention here if tooth is really they will check the strength of damaged teeth. Okay, the remaining to structure or functional requirement. So now doctor need to be actually write more documentation if really he's doing the crown and that tooth really need a crown. He need to clearly mention that this tooth was what is the reason why he's applying for the crown. Okay, so always make sure that doctor have the X-rays, okay, even the pictures, okay, and the very clear documentation which can justify that why he filled for that crown, okay, because like in the audit for sure they will check all the notes, X-rays, pictures, everything. So make sure you are keeping all these things in your documentation in your EMR, okay. About the temporary crown, and so there are updates about this one age, okay. So the dental crown are expected to have a minimum lifespan of 6 years. So before it was 5 years, now 6 years, okay. Then the age I showed before it was 15 years, now 16 years, okay. 16 years and above only we can send for the crown. Provisional crowns, okay. So this one again is very clearly mentioned here that if you are billing or you are sending for the provisional crown, then you need to wait for 6 months to deliver the permanent crown, okay. So if in case you have such case that like really doctor will want to like deliver the provisional crown, then you have to wait for 6 months, okay. Here duration of 6 months during the study treatment, okay. So I'm sure nobody will wait for 6 months to deliver the crown. So in case still if doctor is like billing for the chair side, so you can bill with again with the zero amount, okay. So chair side temporary crown shall not be reimbursed, okay. So this is very clear update mentioned here. So this is very recently update from the payer side. So please make sure you are following the same. Okay, let's talk about now denials. Okay, so in dental, again, as a medical, we are different, like a reason for denials. Okay, so if you talk about the top 10, okay, denials that I highlighted in the blue. Okay, so if you see the first like auth denials, we have auth 1, auth 5, auth 3 denials. So these are all about the authorization. So let's talk about this one first, auth 1 denial. Prior approval is required and was not obtained. Okay, so this is very clearly mentioned that this for example for the outflow orthodontic we need the, or for the crown we need the prior approval, but it was not taken. So one of the reason was what I mentioned before, that one of the reason was that the coder was not aware that, or doctor was not aware that this code need approval. Okay, I will show you one example. We have Pontic codes here, see. So let me click both. Okay, you can see my screen, right? My Excel. Okay, so if you see this one, retainers, for example, if you see right side, so these are all retainer codes, right? Acrylic, for example, these are both acrylic. Okay. So if you see this code, acrylic for the retainer, this need approval. And if you see this one, it doesn't require approval, okay? So now what's happening, sometimes coders assume that all the acrylic doesn't need the approval. So what they do, they simply bill it. So what happened, this clearly goes to denial, okay? So see this acrylic, all right, retainers. And if you see right side, this is yes and this is no. Okay, so that's why I'm always telling that please go to always open this Excel and okay, just find it like this. Okay, how this one, and you will know that this code need to approval or not. Okay, because don't assume that if it is acrylic, it doesn't require the approval. Okay, so please always make sure. So this is one of the reason for auth 1 of this one, the denial. Okay, so auth 1 denials can be of different reasons. Sometimes maybe you send the approval multiple times. Okay, one time rejected or it was expired, and again you send and you get approval. So by mistake, maybe you put the previous approval number. So still you will get it auth 1 denial. Okay, so there are multiple reasons. So make sure that you are putting the appropriate approval number, authorization number in your billing. Okay. Then if you talk about auth 5 denial, so it is inconsistent. So this means that you get approval for example, for the missing teeth, okay, for partial missing teeth, for example, K0.409, but by mistake you put K0.109. So that in like it's not same code. So whenever you send approval, you get approval, you need to put exactly same diagnostic code, exactly same procedure code, and same tooth number. Okay. So auth1 denial is, it means that when you get the approval, okay, you put the different information, okay, or maybe different tooth number, maybe different procedure code, okay. So make sure that you are putting the correct authorization like details. Then auth3 denial is invalid, okay. So this is again one of the like major denial. Why? Because when the coder is typing the authorization number, mostly you will get this denial. So better when you're getting the approval, just copy from that approval number and paste in your like billing window. Okay. If you only like type manually, for sure, because approval number is always big, and now it is like alphanumerical. For example, AUT H1 2 3 4 5 6, like this big number. Okay. So if you will type manually, for sure you will get this denial. So always I recommend to copy from your authorization and paste in your billing. So you will have less chance of getting this denial. Even by mistake you put dot also. For example, you have approval number and by mistake you press that dot only. Okay. So that is also a different approval number. So you will get this one. Okay, invalid approval number. Okay. I will go for the auth4 also. So see, auth4 is for the when you have the expired approval number, you will get this denial auth4. Okay. So make sure that you have your coder, or if you have the different staff for the authorization, make sure that he's checking all the approvals before 1 or 2 days, okay, prior to the like patient's appointment. Okay, so they will know that this approval is valid or no. Not only this one, you can avoid lot of like auth denials when you have the staff who is checking like prior to the patient appointment. You need to make sure that it is valid or no, the codes are okay or no. So all this. So especially for the expired, okay, it's not going to expire. So make sure that. So there was one question before that, if there is last day of the approval, for example, today is 4th of May, for example. So expiry is also today. So you can bill or no? So the answer is yes, you can bill. Okay, you can bill that one today, and submission you can do even next day. So main thing is the billing. The billing date should be not after the expiry date. Okay, so that is important. Submission you can do even after that date, but the billing date should be the same. Okay, so this is about the authorization denials. So most of like high value encounters and high value codes, you will get it auth denials. Okay, so please, your coder or your authorization team, even your doctors, because what approval team sometimes they hand it over that approval to the doctors, because doctor will, or your reception or your scheduling team, they will schedule the patient, right? Okay, so maybe they have to know also. This is like teamwork. So your like front desk or doctor, they need to know also. For example, you will get maybe like approval for only for 2 weeks. So you have to schedule that patient before that approval is expired. Okay, so it is doctors, coders, and like your scheduling team, your front desk. They all need to know that this patient have approval and it is expired on this date. So they need to schedule patient before that. Okay, so all these points they need to know. Doctor have, because most of clinics, doctor, they are putting the procedure code and authorization number to number, but coder is just double verifying. Okay, so again, doctor have to know also that he's adding the correct tooth number. So as a coder, you need to verify always before submitting the claim. Okay, coming to now to eligibility denials. So patient is not cover member. So eligibility also we have multiple, if you see that denial reasons. Okay, so first is not covered. So this is again the front desk task. Okay, when the patient come to reception, they have to know that this patient is covered or no. So now since all the like like insurance, they are giving you the links. Like for example, you have OpenJet, so you need to check that your front desk team need to check that this member is covered or no. Okay, for example, you have, for example, Daman you have. So you have multiple categories for Daman, right? So sometimes you don't know like bronze is covered or no, or Daman Sahatak, Daman Basic. So always like front desk, they need to know this part. So your team need to train them that which card is covered and what services are covered or no. Sometimes card is covered, okay, but that procedure not covered. So that will lead to different denial, okay. So always check your front desk staff to know that this patient is covered or no. Then we have eligibility 6 denial, okay. So this means that prior to the effective date of coverage, okay. So it means patient have the insurance, but the effective date was he did like prior to that one, okay. Eligibility 5 is for the, it means the card expired and he did after that he came, so eligibility 5. That's why you have this one, the links from the payer site, okay. So always ask your friend desk to check whether that card is covered, okay, or expired, or it is, so all these things they need to check. Then we have copay, okay. So again, if you're not billing for the copay, so you will get this denial, okay. So deductible, so make sure that you're collecting the copay from the patient. Okay, then price 1. So whenever you get the contracted price from the payer side, make sure your EMR system, your IT team, they are putting the same amount in your EMR. Okay. Sometimes, for example, you have the claim for example, for the contracted price is 105. Okay, and you bill for 110. That 10 dirhams you will get as a price 1 denial, because they'll say, okay, our contracted price is 100, but you bill for 110. So that could go denial. Okay, 10 dirham will be denied. Okay, so make sure that whatever is contracted price, same is okay imported or saved in your EMR system or billing system. Then we have duplicate. Duplicate is payment already made for the similar services. Okay, so maybe you have done already, for example, you have the scaling polishing done on the like same day, or so you will get, and again you are billing, so you will get duplicate denial. Class 16. So this is the class 16 denial you are getting, but always like quarter, because this is like a term most of the code they don't know, incorrect billing regime. Okay, so this code actually most of in dental, if you talk about dental only, most of denial this one you're getting when you're using the unspecified code with specified. Okay, for example, you have bill for dental care is unspecified, and same you have put dental care is into Dentine also. Okay, so it means there's unspecified and specified code also, so that will lead to denial. Same for example, you have the fracture restoration without loss and with loss for the same teeth, so that one will also lead to class 16 denial. Okay, then we have the duplicate 1 denial. So 1 and 2 are almost same. So actually this one is when you have authorization request, okay, but you have for the same service code, so that will be duplicate 1. Price 7 denial is when you have you submit any code which was not in the contract, so that will lead to price 7 denial. Okay, coming to the clay 12. So this is also submission not compliant with the contract agreement between provider and payer. Okay, so this is again same thing. Okay, if it's on the right side, there are various reasons of consider claim or you will clarify with the man or you submit it. Okay, so it means that you have this code, but not in the contract. So in such case, you have in the contracted price list, you have that one or in your this one, then you can just resubmit simply. Okay. MNEC 4. So this is again one of the top 10 denials. Okay, MNEC 4. So MNEC 4 is when you are not putting the supporting diagnosis. Okay, for example, you have done the scaling polishing and doctor diagnosis only caries. So caries is not supporting the scaling polishing. So you need to have like some, for example, accretion, gingivitis, such code need to be there to support that procedure. And one of the example was, as I mentioned in my previous slide, let me go back in this one. So, maybe you have bill for complete denture. Okay. This one, for example, this one, denture complete. Okay. So if you have complete denture and diagnostic code, you will be putting for the partial. Okay. So this is one of the reason for the, like this one, MNEC4 denials. Okay. So make sure that you are putting the correct code in the billing. Okay. Or else you will get this denial. MNEC4. Okay. So always make sure that you have supporting diagnosis. For example, for frenectomy, gingivectomy. So as a coder, it is very important for you to know which code is supporting, especially for dental. Like we have like if you see, like we have a lot of different categories, right? For prosthodontic, for ortho, for perio, for endo. Okay, so most of for example, any doctor is doing, surgeon is doing the cyst removal. Okay, so you have to add like cyst code. Okay, patient doing the dental like for sometimes what's happening, like for restorations, doctor is putting, maybe he patient had abrasion and this thing. So make sure that if that code is covered or not. Okay, then not covered. This is one of the also not covered. So as I mentioned, some cosmetic services are not covered. Okay, for example, bleaching or veneers. Okay, so make sure again you are familiar with the not covered services. I'm not 5. So this is also one of the, so we see this one too frequent. So when you are billing the scaling polishing, okay, within 6 months, you will get this denial. I'm not 5. Okay, so make sure that again now, since we have now new update for the exams also, and for sure, if you will bill the examination within 6 months, you will get same denial. Okay, so not covered 1. So NCO 3 was the service not covered, NCO 1 is diagnostic code is not covered. Okay. So this is same like MNEC 4, okay? So sometimes this is like supporting, but this is not covered. Maybe the diagnostic code you're putting that is not covered, okay? Then we have code 14 denial. So this denial you will be getting, for example, the doctor is doing the restoration on the primary teeth, but you have billed for the like permanent teeth. So what is clearly mentioned here, diagnosis of activity is inconsistent with the patient age, gender. Okay. So make sure that you are putting the correct procedure according to the age of patient. Then code 10 is for specialty based. For example, you are billing the orthodontic for under GP. For example, you are doing your GP is doing the like braces in this one. So by mistake, maybe you put on bill under him. So you will get this denial, okay, inconsistent with the clinician specialty. Price 2. So this is the code, like denial code you'll be getting. So one example is the restoration again. If you are billing the restoration multiple times for one teeth, you will be getting this denial. Okay, I already mentioned in my slides when I was talking about the restorations. Like before, some period they were paying that if you are billing multiple codes for same teeth restoration, they were paying. Okay, but that is not the correct way. You have to bill for one teeth, multiple surface for one code, not multiple codes. Okay, not multiple line items. So if you bill for multiple line items 3 times, for example, you bill restoration, you will get this denial. So MNEC 3. So this is also like again top 10 denial code for dental. MNEC 3. So for sure, when you're sending approval, always you get this one. Okay. So if you see service is not clinically indicated based on good clinical practice. Okay. So this can be for the different reasons. Okay. Maybe you have sent the procedure code, for example, you have sent the procedure for tooth number 30. Okay. You put tooth number 30, but the procedure code is for the anterior. I'm talking about the restorations, right? So since you know that for restorations, we have different codes for the anterior, different for the posterior, and different for the bicuspids. So maybe the procedure code you have sent is for the, you have billed or you have submitted is for the anterior, but tooth number is 30. So that is, okay, wrong tooth number. This is one of the reason. Other reason is most of you are getting in the approval, right? Approval means you send the approval for crown, for example, okay? But when the pair side, they see the X-ray, they see the pictures, everything is clear, and that tooth is not clearly indicated, okay, not justified, okay. So they want to know that what is the purpose of crowning this tooth, okay. So maybe that can be maybe doctor knows much better. So in such case, you need to, as a coder, you need to talk to your doctor that please, doctor, we got this denial from the payer side. So please justify more why this tooth need the, maybe he has maybe he has cracked tooth from from inner side of tooth, or in the pictures not showing, right. So in such case, doctor need to justify why this tooth exactly need the crown. Okay, so this unlike 3 can be for multiple reasons. Okay, maybe wrong tooth number, maybe not justified. Okay, maybe they need more like picture, or maybe they need to attach the X-ray. So this unlike 3, you'll be getting a lot of times. In the even in the sending approvals, even submitting claims. Okay, so make sure you can, if in such case you are sure that everything is fine, you can just resubmit and the pay will pay. Auth 4, we discussed already. Okay, so time-based code, I already discussed that this was one of the circular we got last year from payer side, that, time-based code, what is the exact time we need to document and when we can bill. So first unit is always 15 minutes, okay? An additional unit can be 8 minutes, okay? So, but minimum time is 8 minutes, okay? So in the new circular, it's saying that actually I need to change here. This is actually 25 minutes for the first unit, okay, and then the 8 minutes for the additional unit. So total should be 23 minutes plus if you are willing for the additional unit, okay. And make sure that your doctor is documenting the time, start and end time. Okay, coming to some of the approvals. When sending approval, make sure you are attaching X-rays, PAs, digital photos, assessment forms. Okay, this for the approval things. Some important points to notice for the audits. Actually, this is for audit, but it's not for audit. Audit means they will check this one, but as your complete documentation, you need to have. You always forget about the audits, but you need to have all these things in your documentation. Okay, what I mentioned before in my earlier slides, that you need to complain that narrative, X-ray finding, procedure note, tooth number, okay, X-ray images, all these things you need to have in your documentation. Okay, so don't always think about audit, but always think about the patient charting, because doctor is not always there. Maybe the but chart will be there for years. Okay, so maybe this patient came like maybe 2 years before. He has this problems. Now that doctor he left already, but this doctor patient notes will be still there, and whoever is coming, whoever will be treating the patient, they will know that what I've done with the patient. Okay, so please make sure that you need to have very clear and very complete documentation. Okay, so as a coder, always please query whenever you find anything missing in the procedure, in the notes, in the procedure note, in the examination, X-ray findings. So always please query physician. So thank you so much. We have actually finished early 30 minutes, so we have the open for the questions. And just one thing I want to mention, that I just talked briefly, but in our next session will be on 1st June by Miss Madel. Most of the dental coders, they know her very well. She's always very active in the groups and replying always. So please go ahead if you have any questions.
Yes, good morning. I would like to ask that if a patient is come for a complete denture, but patient already has four teeth, so what would be the diagnosis code for that?
Yes, doctor. See, if patient have denture already, right? So he has denture or he's coming for the change denture
He
or
is coming for a complete denture with four loose tooth.
yes, yes. See, so first thing is you are going to extract that teeth, right?
Yeah.
So see, this is one of the like good question. I will ask you what's happening here. Sometime because you are attaching the X-ray also when you send for approval, right? So always
Yes.
make sure that you remove the teeth first. Okay, remove the teeth, but you have to send with the complete missing teeth. Okay, so it will be complete adhesionism. Okay, because for sure
Oh,
once you will send the approval, you will send with after removing the teeth, right? The picture and
yeah.
X-ray, right?
Yeah.
So after that only you can send with the complete adhesionism.
So the chief complaint would always be the loose tooth, yeah.
No, it's not loose tooth, it's missing teeth.
But the patient already has those teeth, yeah, in his mouth when he's first visiting the doctor.
Yeah, see, there'll be two things. First thing is you will extract, right? When you
Yeah.
are when the visit, because if in the same visit, because this visit you will first you will extract and then next visit you will deliver the denture, right? The
Yes.
visit when you will remove the teeth, that visit, yes, you will put the loose teeth, okay?
O-
But the
Okay.
next visit when you're going to deliver the denture, that time he don't have any more loose teeth. He have missing teeth now. So
Yes, it is.
you will put chief complaint, patient have missing teeth and he came for denture.
Okay. Okay, sir.
Okay. Okay. Any other questions, please?
Uh, yes, yes, I do have a query. Sir, I would like to ask if a patient come with a complaint of just the chipping of enamel. Otherwise, the tooth is healthy, just chipping of enamel. What would be the ICD-10 code that we should use?
Yeah. Can you repeat this chipping or chip teeth,
Just
right?
chipping of enamel, no? Just a small chip is there and the patient has come for the restoration. So would we use the fractured or broken tooth ICD-10 code or which one? Partial loss of
No,
tooth
for
or cracked tooth?
see, if it is chipped like small, like the part is only gone, then you can put for the chipping will lead to, I think, for the crack tooth.
Cracked tooth. Okay, thank you, sir.
Crack, yeah.
Good morning, sir. My name is Seena. Sir, for fluoride treatment and any particular code is for like a permanent or primary, any different code is there for the procedure?
No, fluoride treatment we have, I think I have the list here. Fluoride treatment we have only one for, there is no different. Let me check if I can get.
But sir, whenever we are billing that one, we are getting rejection for that age, gender, that rejection is there. No, we are getting
No,
that one.
see, first thing is the fluoride is not covered under the insurance. You are working in the private sector, right?
Yes, sir.
No, it's not covered. Fluoride treatment is not covered.
Okay,
And it
sir.
is,
Please, sir, can
and
you
other
please
thing
share that
actually,
uh,
only, in the some like like government facilities for the school screening patient only they are paying for the fluoride treatment.
Okay, sir. Sir, and if you don't mind, sir, can you please share the Excel for that pre-approval needed? Is that
Sure.
possible?
Please send your email to Mr. Sheikh and we will share with you. Or maybe you can just
Where
write
I,
here. You can write in the
where I
chat
need to.
box.
Okay, sir. Okay, sir.
Or,
Thank you, sir.
or maybe local, yeah, that's much better, yes.
Okay, sir. Thank you, sir.
And see,
Okay,
if you are doing the fluoride treatment for the cash patient, the diagnostic codes we have for the risk of caries. This was one of the doubts for the coders, so they have to put in different codes. So we have the codes for risk of caries codes. Those codes you can use, but it is like not covered.
Okay, sir. Thank you so much, sir.
Okay. Any more questions?
Thanks, sir. Okay. Sir, I want to ask regarding the diagnosis fractured and cracked tooth.
Okay, see,
We can assign the cracked tooth like and fractured.
for the same tooth, okay, for same tooth, if crack and fracture, right? So
Yeah, no,
yeah, so
not like
different.
that. Then yeah, different tooth.
Yeah, see, different is for sure. You can use multiple codes. For example, one tooth is cracked, one is fracture, one is with the fracture restoration. So different teeth for sure you can use multiple diagnoses. There is no issue. But what is important is your doctor need to document in the intraoral examination that, for example, tooth number 1 is broken, tooth number 2 is cracked, tooth number 3 is, for example, fracture restoration. So he need to write the tooth number plus the findings. That is the most important.
Okay, if doctor is documenting like the tooth has decay-induced breakage, what we will assign doctor then?
Sorry, what he's writing?
In doctor put the documentation like the tooth has decay-induced breakage, then which code we can assign?
Yes, see. So now, yeah, so this is very good question. Actually, more of the coders, they had doubt this one. So if tooth is decay due to caries, broken due to caries, right?
Yes,
Okay.
doctor.
So now the what is the cause? So that is the like caries, right?
Yeah.
So it is recommended that always put the caries code because caries code is the main reason why this tooth is broken. But if you have the broken teeth due to any other reason, trauma or anything, then yes, you can like build the broken tooth. But for the caries case, code is always most recommended.
Doctor, I have one confusion because doctor mentioned like caries that causing the tooth to broke. So the tooth is broken already now, right? So we still use the caries code.
Even see, I'll tell you, even adding both codes is also fine because there is no like if you see the coding guideline for these both codes, okay, there is no exclude node, so you can even put the both codes, okay. But the guideline is the manifestation because this is due to what, so it is the tooth is broken due to what, okay, due to caries, okay.
Yeah.
So even you can put both also, but I always recommend for the caries because the main reason is the caries which lead that. Actually, that is caries. Actually, it's not the tooth broken, but the caries itself like you destroy that teeth. Okay.
Yeah,
so it is much better to put the caries always.
Okay, because I think when we code mapping, it will as going to crack tooth. I think so, like that. Not the caries code. They are suggesting.
Yeah. So see, the thing is, see the crack, as I mentioned, there was confusion about a crack tooth, fracturation, okay, crack tooth and broken. So see, crack always, like put, as I mentioned, if there is only line, so either you can put the broken tooth or caries, okay. Even putting both code is also fine. I think there's no problem in that.
Exclusion, right?
Yeah, yeah, there's no exclusion, yes.
Okay, doctor, thank you.
Hello. Hi, good morning, sir. For orthodontics, initially the patient visited for the facility and for specific examination. We built it.
Your voice is not clear.
Mm-hmm. Now is it audible? Yeah. Initially, the patient visited to the orthodontic physician, and we built it with a specific code 09102. After some time, the patient visited to the facility again, and the doctor wants to bill a complete examination with the 01. Is that okay to bill?
See, the first thing is the 01902. Are you talking about the which payer, like the man admit or which one, or cash or what?
Yeah, the man.
See, the man, I'm not sure if they're paying for 01902 because 01902 now they are giving only for the second opinion. Okay. So in such case, if you are billing, for example, patient is coming first time, but if you see the 01901, okay, so that will include everything. It means patient was examination is done. Okay, because for sure patient is coming first time, you take the X-ray images and then you're sending for approval. Then you get approval for 01901, right? So in the first visit is always recommended not to, like, you cannot bill for examination because the other thing is now that with the new rules 6 months. So there might be chances of rejections if you are billing 01902 and then 901. So better to always go for 01901.
First visit then.
Yeah, first visit you can only just document. Okay, you can put diagnosis, whatever doctor has finding, then the documentation, and then only once you get approval for the 01901, then you can go ahead and bill 01901.
Okay, but the patient will come back like after like 1 week or 2 weeks or next month. Then only the doctor wants to do complete examination.
Yes, that's the thing, because actually we see the first examination because for orthodontic cases they are sending to second opinion, right? Your patient will go for second opinion or no?
For this one patient we got, and for that they don't want to go for a second opinion.
So see, this is what I'm telling you. If even they are paying it, they might recover or they might reject. With the new this updates, they will reject either 01902 or 901. Only this exception they have given only for 01901 only.
Okay. If the patient is referred first visit and again doctor wants to do this complete, then we can bill it.
Yes. So see, for example, if your own facility you have any GP or any ortho, he bills something, okay, and now he referred for orthodontic, okay, and he bills 01901. Yes, that is okay.
Okay. Thank you so much.
Thank you.
Hi, sir. Good morning. Actually, I have one doubt on this MNEX 003. The diagnosis was gingival recession localized, and the procedure code was this temporary filling code 20111.
Yeah, for sure. 20111. Okay, see, 20111 is for pain control also, right?
Yeah.
That code they use for multiple reasons, for temporary filling, for pain control. Okay, so see, for this one, for if you have gingival recession, you cannot. What is the purpose of this? You have done any procedure? What procedure exactly is done? That is the
No,
question.
I mean the doctor. The note was lead to 20111, and the diagnosis code was in the documentation was localized gingival recession. So actually, I get this denial from this rejection. So what should I do? Means I have to send again a query for that, or
No. See, my question is: patient has gingival recession, right? So now doctor has billed 20111. What is the purpose of it? What procedure actually? She has given any gel or anything for her treatment or what? Some doctors they are giving only medication and they bill for this one, the pain control. So that is wrong.
It was mentioned there's temporary filling done on like that one. The note
Yeah,
was
so
like
see,
that.
so simply, this is if, how can doctor do temporary filling if doctor patient have incision? The incision have nothing to do with the restoration because that is gum like periodontal disease, right? Incision.
Okay.
Incision is a resider of gingiva.
I mean, in the starting, I should have to query that one to the doctor, right?
Yes, of course. See, the incision is for the gum, right? This has nothing to do with the teeth.
Yeah, yeah.
So if you had done that temporary filling, it means patient have maybe caries or some cracked tooth or broken tooth something. So that's why he has done the temporary filling. So always query physician in such case.
Okay. Thank you, sir.
Thank you.
Hello. Yes. Hello. How are you? Thanks
Yeah, good
for
man.
listening. Actually, I just want to. Lately we confused that we have a patient for new crown and the fee the service the month they paid us 1,200, but while we are making billing, it's showing for us 1,560.
So you mean when you get the approval, the amount was, for example, different and you're billing different. Is your question?
Yes.
So
Yes.
see,
What is the reason for
if
that?
you are
They say
whatever
facilities.
see whatever the approved amount you have in your authorization letter, that you can bill only. If you will bill more, okay, you'll be getting like that denial, price denial. Okay, so make sure that whatever is approved, that you need to bill. Sometimes by mistake they are putting the wrong amount in the approval letter. In such case, your approval team need to resubmit that one with mentioning that please approve the correct amount. But you cannot bill more. In case you will bill more amount, you'll get denial. They will pay for the approved amount, but remaining they will deny.
But sometimes we have the opposite situations. They give me more, and once we build, we found it less.
You mean when they pay you less, right?
Yes.
Yeah, and see the first thing
they
is
paid more. Sometimes they bid more.
so see the first thing you need to see your contract. Okay, what exactly was in your they're giving you list, right? When you have contact with any payer, they will give you one price list, right? First thing is you need to check which price is correct, the one they paid or the one you billed. Okay, so this is the first thing. So what is important once you have that contractual price list, for example, for Crown, in your contract it is 1,200, then approval 1,200, then billing 1,200. So whatever is less or more, then you need to, sometime in your software it is wrong. Okay, so in the EMR system, maybe they put wrong. So maybe you are billing for 1,500 and they pay you for 1,200. Okay.
You mean the software they have to upload the new list?
So yeah, so see, always check
From when can we
your
get this list,
contracted
please?
price list. So that price list need to be in your software.
Okay. Is it changeable from facility to facility, the listing fee?
Yeah, of course, there is factor, right? Something called factor. So yes,
Yes,
so
it's according to the factor, right? Because I keep on informing them, but no one can understand me. It's according to the factor that's why you get this amount.
Yes. So factor is always changing. The main price is the same, but factor always clinic to clinic they have different factors. That is different. All facility have a different factor. So that's why whatever is in your contract and factor, that your EMR system need to be updated in your software.
And what available in the contract, we have to update it on the software, right?
Yes, correct.
But actually, when I asked our managers there, he informed that he didn't receive like this prices or like this list.
No, how come? Whenever you have any payer side, you are getting any contract, for sure the first thing is they will send you the price list, right? Quotation. Then you have to sign that quotation, and then only you will get this one.
Mm-hmm. Okay, so
Yeah,
in this case, if they don't
all
receive,
is possible. They will just simply sign and they say bill anything.
I have to email the payers to ask them our list, you mean?
Yes. you need to ask the price list, and then same you need to give your EMR software team, and then same thing they need to same in your software.
Okay, thank you. Can you please send also for me the list that you shared also as well?
Yes, please send email to local chapter this one email, and we will share with you.
Okay then. Thank you. Thank you so much.
Hello. Yes. We've been encountering rejections when our doctor, a pedodontist, has been claiming space maintenance and extraction, like same day space maintenance and extraction. So obviously we cannot code that tooth as a missing tooth. So it's the only diagnosis we're able to add is for the reason why whatever for which we're doing the extraction. Suppose it's a retained root, so we'll only add the diagnosis for the retained root followed by the space maintenance. But we're receiving MNEC4 rejections for this.
Yes, good question. Yes, there was doubt. Yeah, this was doubt. I remember last time also, and there was, see, whenever you have space maintainer, always bill for the missing teeth, whatever, because your space maintainer doctor they're putting for the missing teeth. So always put partial denturism code, and then that's actually the code. You cannot put the code where the doctor will place the space maintainer. You have to put the code for the missing teeth, because doctor is putting that space maintainer due to that to maintain that space, right? So you need to put missing teeth code, then only you get paid for that.
This is a same day extraction and space maintenance. So when we're extracting the tooth on the same day, then we can't code it as a missing.
Why you cannot code? See, you will be building in the same this one, right? On the same, right? What is important are the notes. Okay, in the notes you will put that tooth number, for example, tooth number 19 is extracted and became as missing. So what is important is your notes. You can add both codes even.
So
sometimes what's happening?
The tooth is a retained root, and I'm doing a root extraction followed by a space maintenance. So
yes, you can put both. You can put both.
Yes, so this is tooth number K. So I'll be diagnosing it as a retained root and as missing.
Yes. I will give one example. Some doctor they are doing immediate implant after extraction. Okay, so what they are putting caries on the same teeth, and plus same they are putting implant. Okay, missing teeth. So that is fine as long as you are justifying, you're writing your documentation.
But
okay, so it is justified.
Diagnosing both it as missing and a decay.
No, this is what I'm telling you. This is how you will document. You will that patient came with the remaining root which needed to be extracted. Okay, and in your progress note, okay, you will put that patient came for extraction. Extraction was done. This and this. Okay, remaining root, and this tooth has now like missing. So for sure, it is missing teeth now, right? So you need to document that, and then you can assign the code according to that. Both code you can add. There is no issue for sure. This is justified. I'll give you example, right, for implant.
In the intraoral finding, the doctor will obviously identify this tooth as a decay tooth or a retained root. So
yes. In the intraoral examination also you can write same thing, because if you write only in the procedure note, in the audit they will ask you why there is missing teeth and you did not put there. So you can justify from the progress note itself. But better in the intraoral examination also you write that this tooth is decayed and will be for removal, and in the like bracket, right, tooth will be removed today.
But in the audits they haven't accepted this justification from us before.
No, for sure this is justified. I know the cases where the doctor like even I face like cases where doctor is doing the immediate implant. So immediate implant means same day they remove the tooth and same day they go for implant, remove the okay, so it is justified.
But we've received a comment from the Tasneef auditors that if we document it this way, it's only for the claiming purpose from insurance companies, and it's not the right practice.
No. It's not like, see, it is very clear, like when you remove the teeth, there is space, right? So it's very clear that remove teeth, there is space, and you will bill for extraction and space maintainer. It is very clear. So this is your doctor or your coder. They need to have strong justification. So that's it.
I have. I had
Good. Thank you. Sheikh, can you please share also that you like you are for our dental chapter? So whoever have doubt, they can ask us there also.